At ASH this year, I'll be presenting one of two items that I'd like to discuss. The first is long-term follow-up of the NEJM clinical trial evaluating combination ibrutinib and venetoclax in patients with mantle cell lymphoma. The basis for the study was that progression-free, despite activity of ibrutinib and venetoclax as monotherapies in relapsed and refractory mantle cell lymphoma, but the progression-free survival for both of these agents was still under 14 months. We therefore recognised that there was still an area of unmet need in terms of providing safe, effective, but also durable treatments for relapsed and refractory mantle cell lymphoma. There's also preclinical evidence that the combination of venetoclax and ibrutinib are synergistic, and therefore we sought to answer this question in a clinical trial. We conducted a phase 2 clinical trial as an investigator-initiated single-group study combining ibrutinib initially as monotherapy for the first 4 weeks, followed by stepwise dose escalation of venetoclax with ongoing therapy until disease progression or unacceptable toxicity. We later amended this study to allow for patients who had achieved MRD negative complete response to cease therapy and undergo stringent surveillance. The findings of our primary analysis are already published in the New England Journal of Medicine, and these show that the complete response rate by CT evaluation was 42%, the rate of complete response by PET evaluation was 62%, with an overall response rate of 71%. In addition, many of these patients had achieved MRD negativity, and this was a surprising finding that patients were rapidly achieving deep responses. With respect to our current analysis, the median follow-up is now 37.5 months, and the duration of response median has in fact not been reached, but we estimate that at 30 months, 75% of patients will remain in their ongoing response. The progression-free survival is 29 months, and the overall survival is 32 months. What we found in our cohort of 24 patients was that 17 patients who had achieved response, in the 17 group of patients, 5 patients were able to enter into treatment cessation at clinician and patient discretion. And of these patients, 4 patients remain off therapy. The first patient has had 7 months before progressive disease occurred, and the other patients have an ongoing deep response off therapy anywhere between 6 and 18 months. These patients have been stringently followed up with clinical examination, MRD and CT. Therefore, we have aimed not to miss any occult disease progression. Our findings demonstrate that ibrutinib and venetoclax are in fact treatments that offer durable benefits for our patients with relapsed and refractory mantle cell lymphoma, and we have evidence potentially that treatment may be ceased in a subset of patients while this data is still extremely small in number. This study was an extremely small analysis limited by the fact that we were a single group study. Therefore, Pharmacyclics are conducting the Simpatico study, which is a phase 3 larger scale study that compares ibrutinib randomized against ibrutinib plus venetoclax to answer the questions on a larger scale and in a randomized phase 3 fashion about the benefits of ibrutinib versus combination therapy. I would hope that we would be able to design a trial in future where we are able to take a greater number of patients off therapy to determine which select group of patients will be the most safe to come off therapy and who will have an ongoing durable response. The third major area of need is to answer the question of why those patients who had primary refractory disease or early treatment failures did not respond to therapy, and how we can obviate those resistance mechanisms in that group of patients.